Good afternoon. I'd like to thank the organizers for inviting me to this very interesting meeting and the opportunity to speak before this audience. So I am going to be discussing the HPV-related neoplasia and its very complicated relationship with heart therapy. Because it's a complicated relationship, I'm going to start by introducing the virus a little bit because I think it's important to our discussion. So just briefly, HPV is a small, non-enveloped virus with icosahedral capsid. And what you see here are the virus-like particles that actually make up the vaccine. So it gives you a picture of the virus. And now, it's a large family of viruses. There's over 100 HPV types and more than 40 infect the cervix, of which approximately 13 are thought to be cancer-related. And it produces certain proteins that I want to bring to your attention, a series of early proteins, which are transcriptional modulators of cell replication, and the two capsid proteins. The L1 is the protein that you see in the viral capsid makes up the vaccine, but it also produces E6 and E7, which are the two viral oncogenes, which the E6 protein interferes with P53 and E7 with the retinoblastoma gene and play a major role in the immortalization of cells. Now that's a distinction because what I want to draw to your attention, HPV doesn't directly cause cancer. It leads to the immortalization of cells, but it's the accumulation, and this will come up further in our discussion, of the epigenetic and genetic changes that these immortalized cells can aggregate that actually leads to full transformation. And this is just to briefly show you the natural history of HPV because it shows you how it actually on its own avoids the immune system. So HPV actually enters the body into the skin to a layer, the basal layer, which is a monolayer, just one cell thick of cells, through an abrasion and replicates here, and it only produces at low levels a couple of the early proteins, E1 and E2, and then it follows the differentiation of the skin and only produces some of the other more relevant proteins in terms of replication, E6 and E7, at higher levels as it begins to migrate and the cells differentiate. And it's only in the last stages that the highly immunogenic proteins, L1 and L2, really get expressed. And as the cells die, because the skin on your hand, the cells on the top of your epidermis are not alive anymore, that these are expressed and virus can be shed. So here's a list of the HPV-associated cancers in a meta-analysis of both HIV positive and transplant patients, which show here's cervix, here's vulva and vagina, here's penis, here's anus and oral cavity. And you can see that both for HIV positive, but also transplant patients, each one of these HPV-associated cancers is significantly higher in these two populations. And the nice thing about this presentation is, certainly in the early days, there was a great suspicion that these HPV-associated tumors were elevated in HIV-positive individuals, primarily because they're both sexually transmitted. But obviously, in transplant patients, we don't think that there's an excess of sexual behavior that would explain these associations. And subsequent studies also provide evidence that there's a direct relation to immune status. So, how does this all relate to heart? So here's data regarding the incidence of these same cancers in HIV-positive patients through linkage between the AIDS registries and the cancer registries, okay? So they're both population-based registries. And what you see here is anal cancer in men. The top here is in situ, and here's invasive. I'm going to focus on the invasives. And this is 1980 to 89, so pre-heart. Here's 1996 to 2004, heart. And here you see, despite these immune associations we were talking about, that in the era of heart, you've gone from an incidence of 10.5 per 100,000 to 42. For women, you go from a rate of nearly none to about 11.2 for anal cancer. For cervix, from 71 to 90. So in each of these cases, lower levels for oropharynx, for penis and vagina, but for each of these, there's certainly no evidence of what you might expect as a decrease, but rather an increase in these rates. And let me just show you another example here from a cohort study that recently produced results. So here's for men with sex men, other men, and women. And you can see, going from 1996 and 99 to the current era, certainly there's no decrease in these incidence rates in any of these risk groups. So this is a very busy slide, and I apologize that I couldn't find a better one in short notice, but what you have here are incidence rates of anal cancer by risk group, so men of sex men, other men, women, and after 10 years, this is in the HIV only group, and you can see that the rate in this population is among men for men who are not men who have sex with men, the rate is only 2.55 over a 10-year period out of 10,000 men. After considering competing risk due to other causes, and a similar level, let's say, in women, quite a bit higher in men and sex men, about 14.2 in 10 years out of 10,000. These are unpublished data, just recent analyses, which is why I don't have a better slide. But the rates are so much higher among those who have AIDS. Again, pointing to there being and this again is based on linkage between AIDS and cancer registries. And so here's again evidence of the immune association, and yet I'm telling you that we're not seeing a big impact of heart. Here now is for cervical cancer, the other major cancer. And here is a paper we put out just last year, and so you see here HIV positive women with low CD4, down here are HIV negative individuals and people with HIV positive with intermediate levels of CD4. Down here, this is, just because I'll mention since it's here, this is viral load rather than, HIV viral load rather than CD4 count, and we don't really see strong consistent associations with viral load, but the data were limited in that sense. But here you can see the trajectory of CD4, okay? So here is CD4 count, and this is time since heart, and here's the cases. Their CD4 is going down, and here is time from diagnosis, and you can see here, among the cases, their CD4 count was going down as compared to individuals who were individually matched to them. So how do we explain this paradox? Well, let me just give you a little bit of HPV natural history data. What you see here is the prevalence of HPV, the incident detection, and its clearance. Here's CD4 cell, high, greater than 500, 200 to 500, less than 200. And what you can see is, here's viral load, undetectable, low, moderate, high. What you can see here is for prevalence and incidence, that with decreasing CD4 and increasing HIV viral load, there's this beautiful monotonic association where there's essentially even an interaction between them in terms of size, and here the same in reverse, that you have decreased clearance with increasing HIV viral load and decreasing CD4. But what's noticeable here is even for those who have high CD4 and very low viral, well, undetectable viral load, you still have approximately a twofold effect. So there's even in those individuals with the best immune status, they have an effect. And most of these incident detections, I don't have time to show you these slides, we have evidence that this is a good proportion of these are not new infections, but in fact reactivation. So here is where we begin to understand perhaps part of the paradox. And so what this is among those people who were using adherent and effective HAART, we evaluated, there's a difficulty in analyzing this because the use of HAART in itself may identify women who are frail, and therefore HAART can maybe look incorrectly that it's actually high risk because it's being used in the most frail individuals. And so the data were very messy regarding these associations, whether HAART had a beneficial effect. But no one had looked at whether, if you limited it to people who were adherent, if you limited it to people who are on a HAART regimen that was effective, meaning undetectable viral load, did you see an impact? And what you see here is a comparison of, in terms of prevalence, incidence, and clearance, just like the natural history slide that I just showed you a second ago. For oncogenic HPV, the adherent women versus those same women compared to themselves to deal with that issue over self-selection regarding treatment, a significant, reduction, 40% reduction. We don't see a significant reduction in those who were non-adherent. We saw similar data in terms of those who were on effective HAART. We see an impact on incidence, and there's an impact on clearance. But the thing is, these impacts, even in this carefully designed study, are moderate. Here's another slide just showing outcomes following treatment for CIN. And what I want to point out here is that CD4 count, again, was highly significantly associated. So we see on all sides of this paradox between the associations, but we see this only modest effect regarding HAART. So what I started this discussion by talking to you a little bit about the natural history of HPV and its relationship to carcinogenesis. And what I pointed out is it's not HPV just by itself that is necessary for the development of cancer. It is the persistence of HPV. But it is also the accumulation of epigenetic and genetic changes over time that are necessary to have invasive carcinomas. So, if you have a modest effect of HAART on HPV, and you now have women surviving longer, men surviving longer, so that they can, one, have increased exposure to HPV, the HPV has a greater opportunity to persist, even though there may be some reduction in infections with the modest impact of HAART. And then you have this opportunity with longer infections for the accumulation of these epigenetic and genetic changes that you can end up with a situation where you actually have a increase or a equipoise where you don't have a clear reduction in cancer. Now, Going through a few slides quickly, I'm not going to, regarding the impact of screening, we have improving screening approaches. There's going to be an HPV vaccine everyone knows about. And so there's also other factors that may impact whether we see big changes that relate specifically to heart. And so let me just summarize. So host immune status is associated with risk of HPV, with the incidence of cervical and anal precancer and other HPV-associated cancers. Effective adherent heart use is associated with a reduced risk of cervical HPV and neoplasia. However, the impact of heart on these risks appear to be moderate. Greater longevity with improved but still diminished immune status may create an opportunity for more frequent HPV infection, longer persistence, and the accumulation of epigenetic and genetic changes required for transformation. So these conflicting forces may make it somewhat uncertain whether HIV, at least with current heart, that doesn't necessarily bring back all of immune status, whether that actually leads to the prevention of HPV-related tumors overall, or with greater survival. In fact, we're going to be continuing to see elevated cervical cancer and anal cancer and other HPV-associated cancers in HIV-positive patients. Thank you very much.